Hello and welcome to this edition of Live and Ticking. I'm Fearghal McKinney, head of BHF Northern Ireland. The topic of today's event is how does cholesterol affect the heart? Everyone has cholesterol. It's essential for our health as it's used by every cell in our body. However, too much of the wrong types of cholesterol can cause an increased risk of heart attack and stroke. You've probably heard of good cholesterol and bad cholesterol, which can be confusing in itself. You might have heard of dietary cholesterol and blood cholesterol. Here to talk about all things cholesterol is Professor Manuel Mayer, who's the BHF Professor of Cardiovascular Proteomics at Imperial College London. Manuel will be talking us through his current research project, which goes beyond good and bad cholesterol to look more intricately at biological markers in the blood that can help us identify who is at an increased risk of heart attack and stroke. But before we hear from Manuel, we'll be speaking to Louise McGill, a heart patient who in 2017, at the age of 45, had a heart attack weeks after being told that she had high cholesterol. We'll be hearing Louise's story in just a moment. If you have any questions for our speakers today, you can submit them via the Q&A box throughout the talks. We'll also be joined by Senior Cardiac Nurse Cindy Jodar and Registered Dietitian Tracy Parker to help answer your questions later. We'll try to answer as many as possible. However, if we're unable to answer your question, then you can call our heart helpline and speak directly to one of our cardiac nurses. You can also join our Health Unlocked community forum for support. This forum provides a safe space to discuss living with any heart or circulatory diseases. All of our incredible research is funded 100% by you, the public. If you're inspired by what you hear today, then all donations to support our life-saving work are very much welcomed and appreciated. There's a link to donate in the chat box, should you wish to do so. Finally, before we hear from our speakers, I'd like to ask you a quick poll question. And how would you rate your understanding how cholesterol affects the heart? 1 being very little and 5 being a lot. Now, I'm delighted to introduce our first speaker, Louise McGill, who'll be sharing her story with us today. Louise will be joined by Yianna Theodorou from the Research Engagement team here at the BHF. Over to you, Louise and Yianna.
Hello. Hi, Louise. How are you doing?
Yeah, I'm all right, thank you. Hi.
Thank you so much for being here today and sharing your story with us.
No problem.
So to start us off, can you just tell us a little bit about yourself, your job, your family, your hobbies?
Yeah, well, I'm Louise. I'm 51 and I'm married with 2 children. They were 9 when I did have the heart attack. I work as an operations manager for a freight forwarder. Done that for many years. Absolutely love it. And yeah, my hobbies, I like to usual things, see my friends, like to watch the football with my family, and go on holidays as much as possible.
Wonderful, wonderful. And so I know that you found out that you had high cholesterol when you had your over 40s health check. But prior to that, how was your health, your overall physical well-being?
Yeah, I would say I was generally okay. I would do things like the Pretty Muddy in Durham and the 5K Race for Lives. I wasn't like a die-hard fitness freak or anything, but you know, I would say I was doing all right. I was looking after myself. And food-wise, my diet was always pretty okay. Personally, never been a smoker and more of a sociable drinker is what I would say.
So what happened when you had your over 40s health check?
I got a call from the doctors and just went along for a check, which was just, you know, general checkup, which included having bloods done. And one of those did include having a cholesterol check. And then just waited for the results. And then a few days later, the results came through. And they did say you do have slightly high cholesterol. However, putting together all your other factors, lifestyle and everything, they didn't really see it as an issue. And that was it. I never really gave it any more thought, to be honest with you. I just went off quite happy with that.
And then how long was it after that checkup that you had your heart attack?
10 weeks.
10 weeks. Gosh,
Yeah.
that's a shock.
Yeah.
And can you take us back to that day? Where were you? How were you feeling?
Yeah, I mean, that day I'd just been out with my family. We'd had a nice day out, went for a walk, sort of local to us, headed home. After we went for a meal, like pizza, got home, went to bed, and then it was just after midnight I woke up with this really sort of heavy pain in my chest. And it did concern us as in I got up, but I thought, oh, it's probably just indigestion is what I had thought it would be. So I just went downstairs, tried to sort myself out, see how I, if it was going to improve. Nothing changed because I was trying not to disturb and wake my husband. So I thought I'd just take myself off downstairs. But then it just got worse and I was feeling hot and sweaty and getting sort of quite distressed. And at that point I thought there's something wrong here, but it never crossed my mind it was a heart attack. So I went back upstairs. My children were asleep. I went in to see them I don't know, was I maybe saying to them? I wasn't too sure. I just felt like I had to go and see them. And then I went and got my husband and woke him up and I said, like, I'm really not well. And I think it was me that said, I think I need an ambulance. And we went downstairs and he called the ambulance.
And what happened when the ambulance got there?
Well, it came pretty quick. It was only about 20 minutes, so that was pretty good. I now know sort of afterwards, I think they kind of looked at me and sort of surmised that I was likely to be having a heart attack. So they did all the checks and everything, put an ECG on me, and said, yeah, we're going to treat you for a heart attack. We're going to take you through to Newcastle Freeman Hospital. And that's what they did.
Yeah. And how was your care when you got there?
Fantastic. I mean, it was all a bit surreal at the time. I got, sort of, it was like you see on the TV, a little blue lighted through. And there was a team of people waiting there for me when I got there. Gave me some instant medication. And then they took me through to what was the cath lab. And I had a stent put in because my LAD artery was, I think they said 95 to 98% blocked. So they decided that was the crucial one. So they put a stent in and they went in through my wrist and set all that up, which, yeah, amazing.
I remember you said when we spoke about it before that the doctor said you're going to feel so much better after this.
Yeah, I can remember somebody saying to me, Louise, you're going to feel better soon. And yeah, I did. That pain just sort of was lifted from you. Because it was a real crushing pain. It was scary.
And what was your recovery process like after that?
Yeah, well, they took me up to the cardiac ward, where again, more amazing staff. And I was there for, I think it was just under 48 hours. They supported me emotionally because I just couldn't stop crying. I think I cried for about 3 months solid after my heart attack. And they discussed with me sort of the medication I was going to be leaving with, and also to get a heart nurse to come out to see me and look at getting on a cardiac rehab course as well.
And how did you find that?
That was brilliant. I mean, if anybody has that choice to do the cardiac rehab, it was crucial to me. I wasn't somebody that ever lacked confidence before, but when I had my heart attack, I definitely lacked confidence. I was frightened to go out on my own or even do any kind of exercise. But the 10-week course that I did at rehab, they allowed you to push yourself, but you were being monitored. You were with professionals, so you weren't worried. And emotionally they went through lots of different things with you as well. I think that was a big part in helping me to recover and move forward, definitely.
Amazing. It's such a comfort, isn't it, when you've got those people there just saying like, no, you can push yourself.
Yeah, definitely, definitely.
And sort of how has life been since after cardiac rehab and sort of getting back to normality a little bit?
I mean, I was off work for a little while and I did a gradual return to work. It was hard, you know, I'm not going to lie, it was. It's took some adjusting to, but you know, as time goes on, I do believe that you do learn to live with things. I have yearly checks at the doctors where they do bloods, check my medications still correct. I take 4 tablets a day, which I'm assuming I'll probably be on for the rest of my life now. That's fine. I've upped my exercise regime, which, you know, that works for me as well. And yeah, I mean, generally, yeah, things are going good. Live for the moment, I suppose. It's a bit of a cliche, but yeah, definitely do make the most because, yeah, it could have been so different for my family, definitely.
And how did your family and friends sort of react when they heard you had a heart attack?
Total shock. You know, I sort of saw that ripple effect afterwards, how it affected some close friends and family. And I think it was as well because nobody, you know, you can conjure up in your head stereotypical heart attack, you know, person or whatever, but they were just sort of shocked that it happened to me. It just wasn't like on anybody's radar at all, really. So yeah, but it actually then made other people maybe think a little bit more about sort of their health as well. So it's had a good impact as well, I suppose.
Good. And just lastly, before we wrap things up, how has your life changed since your heart attack? And is there anything that you do differently or you know, any way you think differently now?
I manage my stress levels better now. I don't sort of sweat the small stuff, I suppose. You know, I just want to just carry on with my life. My girls are now 15. I've got my husband. Yeah, I just want to make the most of life, which everybody should do, really. But yeah, things are good.
Brilliant. Glad to hear it. Well, thank you so much, Louise, again for sharing your story on our
No
live.
problem.
Fearghal, it's back to you.
Thanks, Yianna, and thank you, Louise. And can I underscore as well our appreciation for you sharing your story with us here today, Louise. And of course, you'll be around for questions later. Now, our next speaker is Professor Manuel Mayer, who's going to tell us all about his cholesterol research. Over to you, Manuel.
So first of all, thank you for giving me the opportunity to speak here. And just hearing the story from Louise, I think just highlights why we hope our research is important. So you've heard about lipids and you measure lipids in blood, but we are not only measuring lipids, we also measure proteins. And the way we measure them is a technology called proteomics. And we think that this technology and these insights will allow us to hopefully identify patients who are at risk of heart attacks and strokes, to be identified earlier, because just like we've heard before, often the heart attack is the first manifestation of the disease, and it would be much better if we could identify patients at risk at an earlier stage. So what are proteins? You all heard about the genome. The genes are the blueprint for our body, but the genes are not executing the function. The genes are translated into proteins, and the proteins are the building blocks of our body. So the proteins make up all our cells. They make up the community of our living cells. So they are the molecular machines in our body that are encoded by the genes. And we have now novel technological advances, and this is a view of our lab, where we can analyze proteins at an unprecedented scale. And this technology is called proteomics. So similar to genomics, where you can analyze all your genes in your human body, you can use proteomics to analyze your proteins. So why is this important? Well, because instead of measuring just lipids, and you have heard lipid measurements, of course, being very important for assessing your cardiovascular risk, and you should all get your lipids checked in research, we want to complement those lipid measurements with protein measurements. And for cholesterol, there are two types of cholesterol, as was mentioned in the introduction. One is called LDL and the other one is called HDL. But before we go into these details, what is plasma? Because most measurements are performed in plasma. Plasma is taken from your blood, then it's centrifuged, so you spin down the red blood cells, and you end up with a supernatant that's called your blood plasma. And this plasma actually changes before and after a fatty meal. So you can here see that before a meal, you've got this nice yellow fluid, but after a fatty meal, then obviously your lipids you're taking up with your diet are going into your bloodstream, and they turn your plasma really from this yellowish color into this whitish color. And this is all the lipids that are transported in your blood. Now, lipids are fats, and you all know that, of course, water and fat don't mix very well. That's when we do our washing up, we always need to add soap and detergents to solubilize the fat in water. And blood is water, so how does the body solubilize fat? Well, the body's solution was to wrap up the fat inside a particle, and this particle is called a lipoprotein. So again, that has a protein component and it has a lipid component. And the protein component helps to shield the lipids, the fats inside this particle. And these particles are circulating around in our bloodstream, and that's part of their normal function. Unfortunately, these particles can also end up in our blood vessel, and this is when then the disease process starts, and this is when we can get long-term consequences such as heart attacks and strokes. Now, the proteins that we want to study on these particles are called apolipoproteins because they sit on the surface of these lipoprotein particles, and we analyze them by this technology I've explained you before by proteomics. So I mentioned HDL and LDL. It was mentioned there's a good cholesterol and a bad cholesterol. So overall, if you have your total cholesterol measured, cholesterol levels, high cholesterol levels are bad for your vascular health. But there are two types of lipoprotein particles. The high-density lipoproteins, they are carrying what is considered your good cholesterol. And then there's the low-density lipoproteins, the LDL particles, they are carrying what is considered your bad cholesterol. And it's this bad cholesterol, this LDL cholesterol, that we need to lower in order to reduce your risk for heart attacks. And we can do that very efficiently with a medication called statins. These are very safe drugs. They are widely prescribed. They are very efficient in lowering your bad cholesterol. So this is how these LDL particles look like. So you can see these apolipoproteins. In this case, the name is ApoB, wrapped around this lipoprotein particle. And inside, you've got all this cholesterol. So it's shielded from your plasma inside this lipoprotein particle. And by having a healthy diet, you can influence your cholesterol level. Unfortunately, there are some genetic conditions or some inherited conditions where patients may have high cholesterol even without the additional dietary input. It's just in their genes that they're genetically predisposed to have high levels. But the good news is we have very safe drugs, very efficient drugs to lower your LDL cholesterol. And I would all encourage you to get your lipid levels checked. And if you have high cholesterol, start the treatments early because the lower your LDL cholesterol, the better. And if you have long-term low LDL cholesterol, then your vessels are better preserved. However, there are also new risk factors. And one of these new risk factors, which is currently in clinical trials, is lipoprotein little a. It's often called an LDL-like particle because it looks very similar, but you can see it has this additional rainbow-like structure wrapped around it. So it's similar to LDL cholesterol to some extent, but it's slightly different. And it's thought to be particularly bad for your vascular health. Unfortunately, this lipoprotein little a is completely genetically determined. You cannot influence it by the diet. And currently, we don't have drugs to lower these risk factors yet. But the good news is drugs are in the pipeline. They are tested in clinical trials. But at present, if you go to your GP, lipoprotein(a) will probably not be measured. Unfortunately, 1 out of 5 individuals have elevated lipoprotein(a), but most of them wouldn't know because it has never been measured. So what we really want to tackle with our research is what we call this residual lipid risk. So it's important to measure your cholesterol, it's important to measure your bad cholesterol and to start treatment early. But just like we have heard from Louise, often patients who are considered at intermediate risk, they may have slightly elevated lipid levels, but we don't necessarily consider them to be at risk of getting heart attacks. They do get heart attacks because actually most of our patients are at intermediate risk, and it's then really important to identify those individuals who will get on to get heart attacks and strokes, and can we have additional measurements to help identify those patients. And we think we can, and we want to measure the proteins and not just the lipids. And this is basically the conventional measurement is we measure the lipids, we measure HDL cholesterol, LDL cholesterol, we measure triglycerides and other type of neutral fats. But this is always measuring the lipids. What we actually want to do, we want to measure the lipoprotein particles. And in order to do this, we want to measure the lipids and the apolipoproteins. And the analogy here is like the balloon. So the lipids are the air inside the balloon, but the apolipoproteins give this lipoprotein particle different colors, different shapes, and we get more information by having both measurements than by just having the lipid measurement. So we have done this at scale in a study called PROCARDIS. This is a study from Oxford. We have worked together with the University of Oxford, measured these apolipoproteins in 1,000 patients with heart disease and 1,000 controls. They came from 4 European countries. And we could show, of course, that apart from LDL cholesterol and ApoB, there were other apolipoproteins that were very strongly associated with your heart disease risk, and these were lipoprotein(a), so the bad lipoprotein(a) that I've mentioned before, as well as some apolipoproteins that you find on lipoproteins that carry the triglycerides. And these measurements were independent risk predictors from the conventional lipids that are currently measured in the clinic. So we think that as we are getting better in treating high lipids, we may need to expand the measurements from just measuring the lipids to also measure the apolipoproteins. And this is something we are now doing in many research studies. Why are apolipoproteins also so interesting? I mentioned statins. Statins are very efficient drugs in lowering your LDL cholesterol. Unfortunately, they do not lower your, for example, your lipoprotein(a), which is one of these new risk factors that is emerging. But now there are new drugs in the pipeline which can switch off the production of these lipoprotein(a) particles, and they're currently in advanced clinical trials. So we will soon know whether these drugs are actually also beneficial to patients. So we are now targeting apolipoproteins with novel drugs. Therefore, we should measure what we therapeutically target, and we should expand our lipid measurements by these novel apolipoprotein measurements, at least in research, and hopefully in future also in clinical practice. So why is it important? Because I told you that the lipids unfortunately don't just stay in plasma, they also end up in your arteries. And this movie actually nicely shows how your plaques, how your arteries change over time. So here you can see how the vessel wall expands until the lumen becomes smaller and smaller. And unfortunately, when then this lipid core, which you see here in yellow, protrudes into the lumen, it triggers a clot formation. So the platelets aggregate and then it blocks your artery that supplies the heart. This is when your symptoms start. But it is important to remember that your disease has started long before your symptoms. So these plaques actually already start in your early 30s and 40s, and then usually the heart attack and stroke manifests itself only in your 50s and 60s. But the disease that leads to the heart attack and stroke, so these lipid-filled plaques, they are deposited over your lifetime. So that's why it's so important to not only lower your cholesterol, but to also start lowering cholesterol early, not when you actually get symptoms. What is also interesting to know is that usually women get heart attacks and strokes later than men. There's the thought that actually women are protected by their sex hormones, but as we have heard by Louise, unfortunately, some women also get heart attacks already in their 40s. So really, we don't quite understand these molecular differences in the plaques themselves. What is currently done clinically is you can, of course, image plaques, for example, in the neck artery. You can nicely visualize those plaques by ultrasound, and you can see images of the vessel wall and whether there are plaques or whether there are no plaques yet, and you can monitor this over time. But what we are doing is when patients undergo surgery and have severe plaques in the neck arteries, then the surgeons actually take out those plaques in order to prevent those patients from getting a stroke. And then we get access to those tissues. And again, you can see here, this is an example from a neck artery. You can see here these lipids that are protruding into the vessel lumen, and we can analyze those tissues. And this is a very precious resource because we get human tissue from the disease we actually want to treat. And we have now an international collaboration where we use our advanced technologies, our proteomic technologies, to analyze plaques from over 800 patients from different territories in the vessel wall. And we want to understand how these lipids are building up. Is it only LDL cholesterol that's contributing to this buildup of the lipids? Or, for example, is it also these novel risk factors like lipoprotein (a) that deposits these lipids in our arteries? And this is really an international effort. This has never been done before at that scale. And we are really very grateful for the British Heart Foundation to support these efforts. So this is our new lab at Imperial College London. Again, I would like to thank all the collaborators because, of course, this research is always an international effort. It's not just an individual researcher who is trying to tackle some of these problems. But as we have heard by the talk of Louise, more needs to be done in order to identify patients early. And this may involve additional measurements, which are currently not available in the clinic, but hopefully will be available in the future. Thank you very much for your attention.
Thank you very much, Manuel. And as the audience can see from behind you, you're actually speaking from one of those offices that you've just put up on the slides. So thank you very much again. Now we're going to welcome back all speakers for the Q&A portion of the event. We're also going to welcome Senior Cardiac Nurse Cindy Jodhar and Registered Dietitian Tracy Parker. If you have any questions for them, please submit them via the Q&A box now. And as you'll see, there are questions in. I'll attempt to pick them out based on those most upvoted. So I'm going to kick off with Colin Cunningham's question, probably to you, Manuel. You've touched on the genetic side of it, but he's keen to know if there's a direct link between stress and cholesterol, or is it still considered lifestyle, diet, smoking, etc.?
You know, it's well known that it's called this type A personality, right? Having and Louise also mentioned this, I mean, trying to slow down, you know, have less stress, because obviously stress raises your blood pressure, and blood pressure again puts stress on your arteries. And this may be one way how, of course, your arteries are damaged as well. So apart from the lipid levels, there are, of course, other ways to damage your vessels, and this includes smoking, and this includes high blood pressure. So it is important that, you know, we need to tackle the lipids, but you always need to look at your other risk factors in addition. And this is one of them, yeah.
Yeah, a linked question, and you've touched on some of this, but why are some people more prone to having high cholesterol than others?
Yeah, so this can be, unfortunately, partially in your genes, so it can be inherited. And this is why it's so important also to know for your children whether they are at high risk of heart diseases and stroke. And this is the way how these lipoproteins get turned over in our body. And some individuals are more efficient in removing those lipoproteins from the blood, so they tend to have lower lipid levels. Whereas unfortunately others have a different genetic makeup and they have higher lipid levels. Even genetically. And this is why these individuals, you know, at least need to be identified early by at least taking a lipid level, a cholesterol test, and get on treatments early, because the longer your blood vessels are exposed to this high cholesterol, the more damage is accumulated.
Yeah, get that. This for you, Manuel or Cindy. How often should I have my cholesterol levels checked, and what's the test?
I can start, and then Manuel, if you need to add, please feel free. It's recommended for any adult to kind of over age of 20 have their cholesterol checked, regardless of how fit you are or how healthy you are, because as Manuel mentioned, it might be an inherited component to this condition. And when it's checked, obviously, if it's within the normal range, you don't need to recheck it for another 5 or 5 years. But if it's abnormal, then it will be the decision between you and your clinician how you're going to manage to reduce this cholesterol.
Yeah, because there will be some discussion around that depending on how the clinician feels you've arrived at the high cholesterol.
Yes, so it needs to have, they call it a cardiovascular risk assessment. That is not just your cholesterol reading, is other risk factors as well. So they take into consideration, and they calculate this risk assessment that can predict whether you're going to have any heart attack or a stroke in the next 10 years. So all these coming into the consideration when they want to. But if obviously cholesterol is abnormal, you can have some lifestyle habit to improve your cholesterol level as well.
I can see where some of these questions are coming from an individual perspective, but I'll throw this one in. Somebody's saying, can you have high cholesterol if you're on a purely vegan diet? Is that a factor? Go ahead, Manuel.
I can take that one if you like.
Oh, sorry, Tracy.
Yeah. So yeah, vegan diets, we know that vegetarian and vegan diets, so more plant-based proteins in your diet, are good for heart health and general health. So that's including more things like beans, peas, pulses, plenty of fruit and vegetable instead of animal proteins. But like everything, the quality of your diet is what's really important. So if you are substituting animal protein for these healthy plant-based proteins, that's very good for health. But if you are swapping out the protein and are including more processed plant-based foods, as with any diet, the more processed foods you have that will probably have added fats, added salts, added sugars, are not so helpful for your diet. So it's the quality that you need to be looking at when you're taking a food group out of your diet and swapping it for something else. So vegetarians still need to be careful that they're not having too many chocolates, biscuits, cakes, fake meat nuggets, all those sorts of things. They are an added complication to a diet that should be otherwise quite healthy when you go vegetarian or vegan.
Okay. This is around about health tests. And the anonymous attendee saying, are you aware that some health boards do not test cholesterol level during an annual checkup where statins are not being given?
As I mentioned, if you are within normal range of cholesterol, it's not necessary to have your lipid profile checked on a yearly basis. But if you take statins or you are known to have a high cholesterol, then you are entitled to have annual checkup to see where you are, basically.
Okay. Someone else was asking, what are the symptoms of high cholesterol? I mean, obviously in Louise's case, the most extreme case, but are there earlier symptoms, or is it only revealed through testing?
Usually high cholesterol hasn't got any symptoms. It's silent, unless some kind of inherited type cholesterol, that familial hypercholesteremia, that you will present some signs and symptoms, but usually is quite silent. So that's why we are recommending to have cholesterol checked, and really, regardless of how old you are, how fit and healthy you are, be aware of your number.
Okay. Is it possible to have a high cholesterol reading where the good cholesterol level is good and the bad cholesterol level is low? Does that actually makes sense as a question to you?
So the
Go ahead.
I don't know. So the total cholesterol is predominantly made up of your bad cholesterol, unfortunately. So your HDL, your good cholesterol, is a smaller component of the total cholesterol than your LDL cholesterol. So there are some very rare, also genetic cases where people have extremely high HDL levels. But in most cases, your total cholesterol is predominantly driven by your bad cholesterol. But of course, what your GP will look at is the ratio of your good and your bad cholesterol. So if you have more of your good cholesterol, that's of course always more favorable. But it's unfortunately the case that we have more of the bad particles circulating than of the good particles.
And Tracy, this is specific again, but can someone eat egg shellfish if they've high cholesterol?
Yes, there's a slight difference between dietary cholesterol. So that's the cholesterol that's found in foods, such as eggs, shellfish, and offal, liver, kidneys, etc. But and your blood cholesterol is as a result of your body making too much or having too much saturated fat in your diet. But research has shown us that actually that dietary cholesterol has less of an effect than the amount of saturated fat that you eat in your diet. So currently, actually, in the UK, there are no recommended limits on foods like how many eggs you should be having, shellfish, or offal. Now, there is an exception to that. So if you do have familial hypercholesterolemia, which is this inherited form of high cholesterol, then it's important that you do restrict those sorts of foods, because it reduces the amount of circulating saturated fat and then circulating blood cholesterol. So it helps lower that along with statins. So for most people, there's no current limitations on eggs and shellfish and offal.
Okay, thank you, Tracy. And Colin Cunningham, thanks for your earlier answer to his specific question. And he comments that when he was told he had high cholesterol, he was asked, would he like to be prescribed statins or manage my diet? He said his diet wasn't bad, but I mistakenly thought I could. And 8 years later, I had an MI and wish I'd taken the statin route. I just provoke a question from that. Is that your choice at that point, or is the consultant the person to decide?
I think it's going to go back to the cardiovascular score risk. If you score low in that category of having a heart attack or stroke in the next 10 years' time, they might ask you to try lifestyle modification and see whether you can reduce the cholesterol. And after a couple of months, after the management, the clinician might have another chat with you and see that you are not really achieving the target, and then they take you to the medication route and prescribe medication.
And if somebody goes down the statin route, then another question is, what's the most common side effects of starting on statin therapy?
We need to consider that the statins, like any other medications, potential side effects. It's muscle aches and pains. But the recent BHF-funded research study showed that although people reporting that with taking the statins, they can have muscle ache and pains, but when they looked at it in a kind of quite in a bigger population, they realized that it's less connected to have these aches and pains with taking statins. And some people won't have any side effects at all. So it's really can be individual.
Okay. Sarah O'Gara says that she's so pleased to hear about this study. She has high LPA level and HA history too. But she goes on to ask if, however, you wouldn't want additional medication over and above statin and the usual meds, is there an indication of what might be an optimum cholesterol level to reduce risk of heart attack or stroke?
Yeah, so I think measuring LPA will become increasingly important, because unfortunately There's still a lot to do in terms of education. Even if you go to your GP, he may not have heard about lipoprotein little a. And if you listen to Louise' story about, yes, you have slightly elevated lipids, but we don't think it's a problem, that's very common, right? Because the risk is a risk, right? There's a 10% risk you get a heart attack over the next 10 years. Well, this is a 1 out of 10 chance. I want to know whether I'm the one person who gets it or whether I'm the lucky one among the 9 ones who don't. If you actually would have those measurements like lipoprotein little a, it would actually put you probably in a different risk category. And we are missing this information at the moment because many GPs even are not aware of it, and often you need to go to specialized lipid clinics that they actually measure it once. The good thing is you only need to measure it once because it's genetic. If you have one measurement, you know whether you are in the risk group or not. But at the moment, we are not measuring it. And I'm sure for Louise, even if she had a heart attack at the age of 45, probably nobody measured her lipoprotein delay. And of course, this has implications because not just for her, but also for her children, because it's genetic and it can be passed on. So I think there's more to be done really to go beyond our current lipid measurements. What doesn't mean, of course, that everybody should get their blood pressure checked, should get their lipid measurements checked. But what we hope to try to improve upon is to identify the patients who will get heart attacks and strokes earlier on. Because I think this is still an area of need, and you don't want to have the first manifestation of the disease already a heart attack or a stroke.
Okay, we'll just move off the medical side just now and introduce Louise again. Some people are asking here, Louise, how did you just cope after your heart attack? You talked about crying, but also they're asking, how did you find the cardiac rehab and how helpful and detailed was that for you?
Coping afterwards, I mean, I am lucky. I've got very good friends and a good family support network, which I did lean on a lot. But the cardiac rehab, the thing that was great about that, was also when I went there, it was with 9 other people at that time that had been through what I'd went through. So it was, a good way to just talk it out with people, have the moans and groans of why did it happen to me? It's not fair. Which, I think is just the process that probably everybody goes through when they have something like really bad happen in their lives. But the rehab, it was crucial. It did go through diet, it did go through exercise, it did sort of explain things in a lot more detail. I came away with booklets, but it was the support that the rehab gave you. It was just, I kind of look forward to it. It was weird because at the end you missed going, but also you were really proud of yourself that you'd got that far and you'd completed that course. And it put you in good stead for just, getting back to your normal way of life.
Mm-hmm. And was there a psychological element in the conscious of what you were saying about just never ending crying?
Yeah. Well, for me, yeah, I mean, I was just constantly crying. It was very hard to deal with psychologically because it just came out of the blue. It was just, I'd never have said I'm likely to have a heart attack. And I was just going about my business having a happy life. But talking to people definitely helps, whether that be professional or whether it be family or friends. You do learn to live with it. I mean, like I'm nearly 7 years on now. I've got my medication. I take that regular. I go for my yearly checks at the doctors. If I've got any concerns, I would make contact with the relevant departments. I've got my angina spray that I carry around, like a little comfort blanket, I suppose. Well, I've never had to use it. You just got to move on at some point, but it's at your own pace, definitely.
Yeah. Just a specific from you, Louise, somebody wants to know, what was your cholesterol level reading, and is there an average which can be considered or a point at which you consider best?
Mine at the time, just before I had my heart attack, was, I believe the total was 6.8. And that's definitely come down since I've been on medication.
Good. Colin's come back to say, thank you, Louise. Your stories brought his experience back to life. The psychological improvement through rehab was vital in his case, and he feels it's important to call that out. David's asking, Tracy, there are many drinks and spreads available that claim to reduce cholesterol. Are these effective, or are they just comparing with fatty versions?
Yeah, so I think the drinks and spreads you're talking about are called plant stanol sterile drinks, and they're, as the name implies, they're a sort of a nutrient that's already found naturally in many plant-based foods, but not in enough amounts to show the benefit of lowering cholesterol. And that's why you have these particular products that you can find that say cholesterol lowering products. And research has shown that in combination with eating a healthy diet, that they can help have an additional cholesterol lowering benefit of around about 10 to 15%. And there's a specific amount that you should be taking. They recommend about 2 grams every day. So if you're going to be taking them, they are like a medication, like you would take a statin. To see the benefit, you have to be taking these products in that amount every day. Where the research falls a little bit short is actually whilst they are shown to lower cholesterol levels, no long-term studies have been shown to show that they actually lower your risk of having heart attack or stroke. But needless to say, they are out there. You can use them alongside your diet. They are expensive. So you do need to be making sure that you do have a healthy, balanced diet, but you need to be making sure you take the 2 grams in the amounts that they say on the products for any actual benefit. Otherwise, it could be a waste of money. Okay. So they can help.
Tracy, thank you. Cindy, is the questioner here, is the actual number in the CV risk assessment, it's just dropped off the thing. Is it important in itself, or should this be measured over time?
They take all your risk factors into consideration: blood pressure, your BMI, your age, your family history, whether you smoke or not. So all these things, they have a score for itself on this risk assessment, and they give you a total score, and which that score is based on a percentage of how much you are at risk of having a cardiac event or a stroke in the next 10 years. So, for example, if someone has got 2 to 3%, that's a lower percentage. If somebody come like 20%, that's a higher scale, obviously.
Okay. Anonymous attendee is also asking, and forgive me if you've covered some of this, but does having high good cholesterol cancel out the negative effects of bad cholesterol?
Do you want me to answer? Or
yes, or Manuel?
Yeah, I can. I mean, that's why you look at the ratio. So the ratio that's taken into consideration between the good and the bad cholesterol. But the role of the good cholesterol is, in terms of causing the disease or reversing the disease, is still controversial. So statins work very effectively, very safe drugs, because they lower your bad cholesterol very efficiently, much more than you can achieve with some dietary supplements. So that's why they have this big impact on improving outcomes. We haven't been so efficient yet in raising the good cholesterol with drugs, and the drug trials that have been done haven't really shown a major benefit in terms of outcomes. So there's more to do. We're very good in lowering the bad cholesterol. We haven't found yet, or they're still looking for the best ways to make the most out of the good cholesterol. But for now, the best strategy, in addition to diet and exercise, is lower your cholesterol with statins, because they are very safe drugs, widely used. But I think we also need to bear in mind that, cardiovascular disease is not just about diet and exercise. Unfortunately, there are some people who have genetic conditions. We need to identify those individuals.
Yeah. And another question on the same sort of theme is, without minimizing the importance of diet and exercise, This person says they've been left with the feeling after speaking to the GP that major reductions in bad cholesterol will only come by using statins. Is his understanding or her understanding correct?
I can't discuss individual circumstances, so I don't know why the GP chose that pathway, but it's normally based on the other risk factors they have and family history, and whether they can make any lifestyle changes as well, it basically is going to be a discussion between GP and patient.
Yeah. And Cindy, how often should someone in heart failure have their cholesterol levels checked?
Being in heart failure, it's not a different group of people when it comes to this. So it's again coming under a general category of whether you have high cholesterol or you don't. If anyone is on statins or lipid lowering medication, normally they need every once a year. If they are not on a statin or any medication, and their lipids are within the normal range, they don't need to be checked that frequently. So it's all really coming back to the individual circumstances.
Manuel, how far away are we from drugs in relation to lipoprotein and apolipoprotein?
Yeah. Well, the first clinical trial results will be coming out in, I think, 2 years' time, or 1 year's time, actually, 2025. So I think it's a very exciting time to be in medicine because there's a completely novel way how we can deal with these lipid disorders, right? Statins is a small molecule. It blocks your enzyme because our liver makes cholesterol and we can stop making this cholesterol in the liver. But now there are new drugs where we just switch off the protein production entirely. So rather than being a chemical inhibitor, we can just actually stop the production of the protein. And this is where you have seen this long table of a whole range of novel drugs where they target this protein component of the lipoprotein to change your lipid profiles. And again, I think we look very much forward to the outcome of these trials because it would be the first time that we can go after these risk factors, because a risk factor per se doesn't mean it's causal, right? There's an association between the risk factor and the disease, but we don't necessarily know if we actually impact the outcomes if we lower that risk factor. So this is something we need to see in the clinical trials. Does actually lowering Lp(a) really reduce the risk of heart attacks and strokes? We know there's a very strong association between the plasma levels and the events, but there isn't a clinical trial yet to show that it actually can intervene and prevent these heart attacks and stroke by lowering lipoprotein A. But it's not far off. 1 or 2 years down the line, we know the first clinical results. And there are also many other clinical studies where they test these novel types of drugs where you switch off the apolipoproteins in specific conditions.
Okay, thank you very much. Another question is asking, can you have too low cholesterol?
Well, that was always the worry, right? So there was always the worry that because cholesterol is essential, we need it for all our cells, we need it for our cell membranes. That's why our liver makes it. Even if you don't eat any cholesterol, the liver will make some. But it turns out that some people who have, again, a genetic condition which gives them very low cholesterol, they're actually perfectly fine. And they have almost no risk of heart disease and stroke. So it's a bit like, I don't know, maybe an analogy is like, your hard water and your washing machine. The longer your washing machine is exposed to hard water, the more calcification and the more calcium buildup you'll get. It seems to be the same with our lipid levels. The higher our lipid levels, the more likely our arteries are going to clog up. And there isn't really a lower limit. So that's why the new guidelines are the lower, the better. And if you look at the clinical guidelines over the last 10, 20 years, the threshold for giving statins has come down and come down and come down. Why? Because there was actually no threshold where it was safe. The lower your lipid levels, the better it is for you. And giving statins earlier and getting these lipid levels down longer over your lifetime, that's what gives you protection. Yeah, we don't want to start the patients once they had their heart attack. We should start them earlier.
Okay. And of course, we've talked about the condition. We've talked about potential cures around or drug cholesterol reducing drugs. This questioner wants to take it a stage further. What about the potential damage of statins to the liver? And this person can't take high-dose statins.
Yeah, so that's why you get tested, right? So the first time you put on a statin, there's a blood test where they check your liver parameters, because in some individuals, there's an effect on the liver. But this is why this is tested. The first time you put on a statin, you take a liver test before and after you are put on the statin. And then basically this is taken care of. But as was mentioned before, statins are extremely safe. They're widely prescribed. And if anything, they're underutilized, because we know of the huge benefit they have on the risk of heart attacks and strokes. And yeah, people shouldn't be worried to be on a statin. When they're prescribed a statin, this liver test will be done initially in order to rule out the complication. The only other side effect, as Cindy said, is this muscle pain or these muscle aches. But again, this can often be easily addressed by just titrating the dose. And if you're on a lower dose, you don't have these side effects.
Okay. A reasonably lengthy one here, but the gist of it is that this person was tested post-Christmas when their cholesterol level appeared to be high, but it eased off in itself afterwards, and they're asking, can bad eating or bursts of eating in terms of overindulgence affect cholesterol levels? Tracy, maybe?
Yeah, I mean, I think the bottom line here is about the longevity of the length of time that your cholesterol's raised. And like everything, you can have peaks and troughs in terms of how well you are committed to healthy lifestyle decisions, and that can be equally, exercise as well as diet. And I think overall, if you are following or having a healthy lifestyle, those little blips probably are not going to be the problem. It's what you do in the long term, really, that's more important to keep your overall cholesterol levels, your blood pressure levels, your weight down. All those parameters really over the long term are key. I don't know whether you agree with that, Manuel.
Yeah, absolutely. I think it's, this is the advantage we have for prevention, that we can do a lot ourselves by changing our lifestyle before we need to take drugs. But on the other hand, I think we need to be aware that there is a genetic component, and that we often have the perception is like, look, heart attacks and strokes, it's the fault of the patient because they didn't lead a healthy lifestyle. Whereas actually often it's quite the opposite. Some people just have a genetic condition that raises their lipid levels, they are unaware of it, and that leads to heart attacks and strokes. So I think we are a bit in this wrong perception that, if you got cancer, this is really no fault of your own. Cancer just strikes out of the blue, whereas heart disease, it's all preventable by just exercise and diet. And it is to a certain extent, but to a certain extent it is not. And that's why we also have heart diseases and strokes often running in families, because there is a genetic burden that's passed on through the generations, and we need to identify those individuals and intervene earlier, because they wouldn't be picked up by the normal lipid tests. Just like Louise said, right? Her cholesterol, yes, it was 6, right? The threshold is 5. It's not something that sets off alarm bells in a clinician. And yet, in the middle of her 40s, she has a heart attack. And she's a woman, so she shouldn't have a heart attack at this age. But what are the follow-up investigations that have been done to pin down why she got that heart attack risk early? And an obvious thing would be to do a one-time Lp(a) measurement. Maybe this is part of her risk profile, because we are all individuals and we have individual risk profiles, but we are missing currently a lot of the risk. But nonetheless, the risk that we can capture, we should assess, because there's a lot we can do already.
Okay, thank you very much indeed, Professor Manuel, Louise, Cindy and Tracy. And thank you for watching this edition of Live and Ticking. We hope you've enjoyed hearing from all of our brilliant speakers. Before we wrap up, I'd like to ask you a final poll question. And how would you rate your understanding now of how cholesterol affects the heart? 1, very little, and 5, a lot. And if we haven't managed to answer your question today, then we encourage you to visit our Heart Helpline, where you can contact our dedicated clinical team about your query. This is all made possible by you, from your generous contributions and support. If you'd like to make a donation towards our life-saving research, there's a link in the chat box to do so. Live and Ticking is a monthly webinar series, and we strive to produce the best events possible for you, our audience. Your feedback and comments are crucial to help plan and develop future events. So we ask if you can complete the survey at the end of this event or through an email you'll receive in the coming days. This Live and Ticking event was recorded and will be available on our YouTube channel from next week. Our next Live and Ticking event, titled What's Causing My Chest Pain, will take place on Wednesday, the 28th of February. You can register using the link in the chat box. Thanks again for joining us. Goodbye.